My name is Erin Weber, and in this presentation, I'm going to review the impact of fibromyalgia at the individual and societal level, discuss primary, secondary, and tertiary prevention strategies, and explore change theory as it relates to health policy and population health outcomes. One of the lesser understood chronic illnesses that has witnessed an increased prevalence in the 21st century is fibromyalgia. Fibromyalgia is now one of the most commonly diagnosed chronic pain conditions. Until the latest revision of classifications and published diagnostic criteria in 2016, the American College of Rheumatology, or ACR, criteria for fibromyalgia, existing since 1990, was based off of clinical symptoms including chronic widespread pain, sleep disturbances, and fatigue. In 2016, the ACR defined fibromyalgia as widespread pain and pain on palpation of at least 11 to 18 tender point sites throughout the body, lasting 3 months or longer, with no other etiology for the experienced pain. In a qualitative study of 48 females with fibromyalgia, participants reported constant debilitating pain on most days, severe fatigue and altered sleep patterns from either too much or too little, impaired cognition, primarily memory and thought processes, significant emotional disturbances, namely depression and anxiety, negative impacts on the ability to participate in social engagements and make commitments to work or school, increased burden on spouses and other family members, and significant financial repercussions. Specifically, individuals described that the pain, lack of energy, fatigue, and depression associated with fibromyalgia renders them incapable of performing activities of daily living, such as household chores like grocery shopping and house cleaning, athletic leisure activities such as camping, hiking, and bicycling, and even sometimes self-care like bathing and showering. Without diagnostic criteria existing until recent years, many individuals suffering from fibromyalgia relate poor health-related quality of life and have been subject to speculation of the validity of any true physiologic etiology of their reported symptoms. According to the National Fibromyalgia Association, the prevalence of fibromyalgia is 3 to 6% globally, with 75 to 90% of those diagnosed being women. And while a gender disparity has been consistently demonstrated, no ethnic disparity has been appreciated to date. The highest prevalence of fibromyalgia worldwide is in the US at 6.4% as of 2014. The physical, emotional, and socioeconomic impact that fibromyalgia has on even one individual and their family poses a considerable encumbrance to the greater healthcare system and society at large. It is key that preventative strategies be evaluated to offset this burden. The CDC explains that primary prevention strategies intervene before health effects occur. This may include measures such as vaccinations, altering risky behaviors such as poor eating habits and substance abuse, and banning substances known to be associated with a disease or health condition. Despite diagnostic criteria, the etiology of fibromyalgia is still vague. It is not an autoimmune, inflammation, joint, or muscle disorder. Rather, evidence suggests that dysregulation of neuropathic pain signaling occurs. One study suggests that there is also a familial connection that is linked to the genetic variants of serotonin, dopamine, and catecholamine intracerebral system. However, no specific prevention of this risk has been elaborated upon. Therefore, primary prevention or risk reduction of fibromyalgia is difficult to ascertain. In a systematic literature review using the terms fibromyalgia and primary prevention, with inclusion criteria set for relevance to topic, peer-reviewed articles 10 years old or less, and full-text availability, PubMed produced 18 results, of which only one article specifically talked about primary prevention. ScienceDirect produced 77 results, although none of which specifically discussed primary prevention of fibromyalgia, and CINAHL produced no results. The one article that did was published in 2008, and at that time, Altomonte and colleagues reiterated that because diagnostic and classification criteria were not universally accepted, primary prevention was difficult to specify because there are not any specific laboratory or instrumental tests to determine risk factors for the disease. However, they suggest that primary prevention might include intermediate care of acute pain episodes and of somatoform disturbances. To generate a few more ideas for primary prevention, I broadened my approach to reviewing general practice guidelines and literature regarding the clinical management of fibromyalgia. Hauser and colleagues suggested that physical activity is not only an evidence-based intervention for pain reduction in fibromyalgia, but also is it is supported primary prevention strategy for the risk reduction of the majority of chronic illnesses. Another idea in relation to general self-management of health is Hunt and Boggs suggested individualizing exercise regimens and teaching sleep management, relaxation techniques, and pain management strategies. Secondary prevention refers to screening to identify diseases in the earliest stages, before the onset of signs and symptoms, through measures such as mammography and regular blood pressure testing. Again, strategies for this level of prevention in fibromyalgia are limited by the vague etiology. A systematic literature review was performed using the same databases and a Google Scholar search, only this time the terms included secondary prevention or screening and fibromyalgia. Altomonte and colleagues suggest paying attention to previous pain episodes, pain reports from various locations on the body, tender points, distress, somatization, fatigue, and sleep disorders, as these may predict the development of chronic pain. Other contributing factors to screen for include family history of pain, low educational level, low socioeconomic group, and a lack of social support. Furthermore, stressors that are temporally related include trauma, infection, specifically Hep C virus, HIV, and Lyme disease, emotional stress, catastrophic events, autoimmune diseases, and other pain conditions. Secondary prevention strategies designated by Arnold and colleagues include patient self-ratings of pain, stiffness, fatigue, and sleep, the patient and physician global assessment of improvement, tenderness as measured by tender points, and the physician-developed fibromyalgia impact questionnaire, or FIQ. Although they pointed out that the FIQ is limited because it is only oriented toward high levels of disability, does not assess degree of effort to complete a task, and does not adequately assess the other functional domains, including impact on social and occupational functioning. Marcus, Bernstein, and Albrecht developed a validated 6-question self-report fibromyalgia screening tool based on updated ACR criteria. When compared to a clinical diagnosis of fibromyalgia, the self-report questionnaire significantly and successfully differentiated these patients from other comorbid conditions that are associated with chronic pain. While some screening tests and secondary prevention strategies exist, there is definitely a gap, yet again primarily related to non-existent laboratory findings or instrumentation related to the diagnosis. Fibromyalgia has a significant psychosocial and disabling impact on individuals and their families and relationships. Individuals relate a change in their perception of self, loss of intimacy and social isolation, and it poses a financial burden to individuals, the healthcare system, and society because it is an unpredictable and fluctuating course and requires a multidisciplinary approach to a complex presentation with numerous comorbid conditions. Altomonte and colleagues emphasized that it is not realistic for primary care providers to manage fibromyalgia alone, and that it requires a multimodal approach and multidisciplinary team using cognitive, behavioral, and educational strategies. Here is where we finally have some specific strategies that relate to fibromyalgia. Tertiary prevention refers to the management of disease post-diagnosis to slow or stop disease progression through measures such as rehabilitation and screening for complications. In a review of numerous randomized control trials, Arnold found that promising pharmacological approaches to fibromyalgia management include SNRIs, duloxetine, and milnacipran, and alpha-2 delta ligand pregabalin. In a systematic review of non-pharmacological interventions, Arnold found that the evidence is most supportive of low to moderate intensity aerobic exercise. Although exercise does not consistently improve major symptom domains of pain, fatigue, sleep disturbance, or psychological symptoms, it is associated with increased cardiovascular fitness, pain pressure thresholds, global well-being, and self-reported physical function. Cognitive behavioral therapy has not shown to be more beneficial than group education or social support, although it may be effective for targeted outcomes such as improving function, sleep, or coping. And alternative therapies such as acupuncture, homeopathy, nutritional supplementation, chiropractic care, massage, relaxation, biofeedback, and hypnotherapy do not have an existing evidence to support implementation specifically for fibromyalgia, although evidence might exist for the major symptom domains individually. In a study by Hauser and colleagues, the recommendations include sleep hygiene as first-line treatment for sleep problems, with evidence also suggesting insomnia-focused cognitive behavioral therapy to be effective, using cognitive behavioral therapy to reframe psychological barriers to treatment and sustainable health behaviors, and acknowledging and treating comorbid conditions. The American Family Physician Guidelines make grade A recommendations for 2 interventions, which means there is consistent, high-quality, patient-oriented evidence to support them. The first is low-dose aerobic exercise, which equates to 20 to 30 minutes, 2 to 3 days per week to improve symptoms of pain and fatigue. The second is prescribing tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors, and/or cyclobenzaprine, which have been shown to improve measures of pain, sleep, and quality of life, as well as tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors for fatigue-related symptoms. Whereas some of these suggestions might be considered primary prevention in other chronic illnesses, with the unclear etiology of fibromyalgia, current management strategies are predominantly tertiary. Pain is one of the primary features of fibromyalgia. As mentioned previously, it is presumably related to dysregulation of neuropathic pain signals. A number of current health policies and recommendations affect the fibromyalgia population because they pertain to pain management. Per the American Association of Neuromuscular and Electrodiagnostic Medicine, opioids or narcotics are not to be used as first-line treatments of neuropathic pain. And per the American Society of Anesthesiologists, opioid analgesics are not to be used as first-line treatment for chronic non-cancer pain. In 2017, the U.S. Department of Health and Human Services unveiled a 5-point opioid strategy. One of the aims is to advance the practice of pain management to enable access to high-quality, evidence-based pain care that reduces the burden of pain for individuals, families, and society, while also reducing the inappropriate use of opioids and opioid-related harms. Brewer, Lee, De Silva, and Crick explain that the theory of change is typically developed using a backward mapping approach which starts with a long-term outcome and then maps the required process of change through interim outcomes. Connell and Kubish suggest that implementing a theory of change that affects policy change involves multiple stakeholders and consideration of what the longer-term outcomes seek to accomplish, what interim outcomes and contextual conditions are necessary to produce these long-term outcomes, and what the required process is to achieve these outcomes. Considering the organizational and government health policies and recommendations, the long-term outcome as it relates to fibromyalgia might be to reduce the administration of opioids. Realizing the etiology of fibromyalgia is poorly understood, one interim goal might be to increase research efforts to potentially identify risk factors which would enable primary prevention. Since the publication of national restrictions for opioid medications, the National Fibromyalgia and Chronic Pain Association started sponsoring Together Walks, which aim to increase awareness and funding for research. Another interim goal might involve increasing recognition of diagnostic criteria as well as screening tools to improve early and accurate diagnosis for fibromyalgia, which would strengthen secondary prevention measures. To this end, the Fibro Collaborative and other fibromyalgia organizations have started to publish more information and increase visualization of diagnostic criteria. And still another interim goal might be promoting physical activity and non-opioid medications, as discussed earlier, as first-line treatments which apply to tertiary prevention. In order to do this, clinicians will need to be made aware that practice guidelines do now exist in resources such as the American College of Rheumatology, American Family Physician, and UpToDate. Long-term use of opioids is associated with severe physical and psychological consequences as well as increased mortality. Involving various stakeholders in applying theory of change to national health policy and recommendations to reduce the inappropriate use of opioids can potentially activate efforts to enhance prevention strategies. In review, health initiatives, specifically prevention strategies for fibromyalgia, are limited by its poorly understood etiology, progression, and only recent determination of agreed upon diagnostic criteria. Currently, prevention strategies are chiefly tertiary and focus on disease management and reducing physical, psychological, and socioeconomic consequences. There are clear gaps in determination and recognition of risk factors as well as screening measures. These gaps present an area for heightened research efforts and the development of health-related interventions to reduce the burden that an increased prevalence of fibromyalgia poses to public and population health. Using theory of change to guide multidisciplinary goal development with national health policies in mind can conceivably bolster prevention strategies, ensure best practice recommendations are utilized, and improve healthcare outcomes pertaining to fibromyalgia. Thank you, and this concludes my presentation.